Thank you for being here on this Friday afternoon, evening. I'm a little bit jet lagged, so I'm totally lost that we are Friday and totally lost what time we are, but I'm going to do my best not to talk Flemish and only English. So if I do talk Flemish, I have my who will sign me. So I would like to thank Behavioural Institute for Advanced Studies. And of course, Dr. Ipsiroglu and Dr. Stockler for being the hosts and actually pushing this agenda forward. I'm thankful and honored to be here because, as Osman already mentioned, I'm very passionate about what is ongoing. Apart from sleep and typically developing children, I firmly believe that within the group of children that are atypically developing, there is much to learn and much more to be done. So Behavioural makes it feasible for me to travel, and I enjoy traveling and I enjoy being in Vancouver, especially the air. I have my plastic bag to capture some Vancouver air. So I'm looking forward to coming back, and I hope that I provoke enough thoughts, and that especially for the parents that are present, that I can help a little bit by being their voice and putting the agenda forward. So the consequences of chronic sleep deprivation. Now, throughout my talk, I'm hoping to educate you a little bit in terms of sleep, but not only sleep. As Osman said, I'm passionate about this night and daytime behavior and the interrelation about it, and that's where I think the key is in the Sleep2Treat. So my title could actually be Consequences of Poor Sleep, because it's going to cover actually any aspects of non-optimal sleep. And you do not need a sleep expert to explain you that sleep is important or it needs to be optimal, because right now for me, being jet lagged, I know how I feel, and if you didn't have a good night's sleep, you know the next day as well how you feel, how you behave, and how you will perform. Imagine for these children having on a daily basis, on a nightly basis, not the optimal sleep. So, as I said, the objectives of today is a little bit of education in terms of what is sleep, and then I'll continue with the night and daytime behavior interrelation, and then actually how we can see this Sleep2Treat, or how this sleep perspective can actually add into a new way of treatment or a new venue in children with atypical development. So regarding sleep, I'm unaware of your knowledge, but first of all, there's many questions left over, especially in terms of development. So apart from that, what we know is that the brainstem and the hypothalamus actually sign to the cortex. So within the brain, there's a lot of action ongoing. Namely, there are centers that increase or provoke this arousal, and at the same time there's networks within the brain that inhibit this arousal. And actually these centers are being considered as a kind of a flip-flop switch. So a flip-flop switch that is influenced by internal factors as well as external factors. Internal factors might be temperature, metabolic, brain, neurotransmitters. External factors, if you turn off the light right now, I will be the first one to doze off. So, and then I put it right on the spot because the light is a key one, especially the suprachiasmatic nucleus. It's the size of a grain of rice, so, and it has over 50,000 neurons that are in that tiny little piece, and it actually is very important and dependent on that light. So melatonin is actually related, it's a direct connection with light. So the suprachiasmatic nucleus is also commonly said to be our master clock. It's the one that will arrange most of our body functions. And as I just mentioned, the melatonin is one of them, and I come back to that melatonin, and maybe one of the presentations will also address it on the adverse drug reactions or something in treatment. So, because this in adults, you see here about 2100, the melatonin secretion starts, And you can actually see in terms of all the clocks that are ticking within your body, you actually see around 7:30 that the melatonin secretion stops. So that is a key one and is commonly used within children with an atypical development. So suprachiasmatic nucleus, your master clock, actually making that circadian rhythm, making that 24-hour rhythm, but also interconnected to many more biological rhythms or clocks within your body. Another aspect is a sleep drive, or the homeostatic aspect of sleep. And as you can see here throughout development, you see that a 2-year-old, 5-year-old, 10-year-old, and 15-year-old, that when you develop, you also see that that sleep drive will change. And you can see that, as it is stated here, the sleep, so the sleep pressure actually will increase, and pressure accumulates, accrues more slowly during the day with increasing age. So that actually shows that you will become biologically tired, and then eventually you will flip into that sleep stage. And then actually when you are fully rested, then you will flip into that wake state. So the flip-flop switch is something that is quite key to pick up throughout this presentation. And then, as I said, it's not only the internal factors, but also external factors. And one of them is the light, but it's also the temperature, it's how you sleep, where you sleep, the noise. All these elements actually will come into play and will actually help you to fall asleep, or actually prevent you to fall asleep, or make you awaken quite often. Imagine children with atypical development and their sleep ecology, their sleep environment. So sleep is being considered as a window on brain maturation, on brain development, and this is a slide that should actually help you understand that. So you can see that sleep, in contrast to what most people think you do when you are dead, you know, you have plenty of time to sleep then, so now you need to be fully active. Well, actually that's quite incorrect to do that, because sleep on itself is a highly active brain function, and at times it's even more active than during the wake state. So you can see throughout this slide that it changes throughout your lifespan. So we have the REM sleep and the non-REM sleep. The REM sleep, or the rapid eye movement sleep, or the paradoxical sleep, where your breathing, your heart rate, everything increases, also your brain activity. But then again, paradoxically, you know, you're not expressing or exhibiting any of the behaviors. It's also considered as a sleep where we tend to dream. So if something goes wrong throughout that spinal cord, then you actually, that blocks expressing or things that you're dreaming, then we talk about REM sleep behavior disorder. And then the non-REM sleep on itself is even subdivided in 3 to 4 stages. And it goes from lighter sleep all the way to deeper sleep. So when we are born, it's like a 50-50% of distribution of REM and non-REM sleep. And when we get older, you see that that proportion changes, and the proportion of non-REM sleep stays quite substantive, because that is actually also considered as a sleep, the restorative sleep. For children, it's quite important for the growth hormone secretion. So this is important to restore and actually grow and build your own body and the cognition, emotion, all developmental aspects. So the question, or the thing that you should keep in mind, is we sleep the most in a period where we actually learn the most. But I could state it the reverse. We learn the most in the period where we actually sleep the most. We develop the most when we actually sleep the most. Look at children, look at the amount of time they spend to sleep. And still there's so little known and so much overlooked regarding sleep problems in children. So the main question any sleep researcher will have is, how many hours do we need to sleep? Well, very few of us will risk to give you a fixed answer to that, because we actually don't have a fixed answer to it. The only thing we can answer is, you have slept enough, you know, when you wake up spontaneously, and when your body has recovered, restored enough So when biologically, actually, the flip-flop is ready to go to the wake state. But then again, the environment, the alarm clock, school time, extracurricular activities, etc., maybe not allowing us to sleep the amount that we need to sleep. So this slide actually shows you at the age of 1 month all the way till 16 years old that you have, and I should have put it in color, the middle line is like 50%, but there is a huge variation. So there are children that will sleep more than other children. There are children that will sleep less than other children. And that makes answering the question, how much sleep do I need, very difficult. The best answer that we will give is you need to make sure that you can sleep as much as your body needs, as well as you, as long as you wake up refreshed, alert, and you don't feel sleepy or sleep deprived throughout the day. So that is quite hard in terms of children because that actually relies on how you observe them and how you interpret their behavior. And with children, being tired or sleepy can be either by very externalized behavior, but also by internalized behavior. It can be all over the place, or they can be drowsy and sleeping in your car seat. So this is a summary of normal sleep. Now allow me to go a little bit more in detail, because I think in terms of children with atypical development, it's key that you understand what is actually happening in the brain. As I just said, and I'm just highlighting a couple of things, as I just said, the brain is quite central here, and the brain waves throughout sleep is not that it's non-activity, but at times it is even more active than during wake. So let us just look at the wake state. So the arrow you can follow, this is actually an electroencephalogram where you can see the brain waves, and you can actually see that random fast alpha activity is seen, and this is actually what we would then label as awake or wakefulness. And then actually, as I said, the sleep state is divided in that REM and non-REM, and now the non-REM sleep is considered to be in parallel with cortical development. And so the brain waves are quite important here. So what you see is you go to bed as an adult and you have your stage 1, and then stage 1 is mainly theta waves, and then it's like 4%, 5% of your total sleep time, the time that you will spend to sleep. And you see that your brain waves will gradually change when you go into that deeper sleep, that more restorative sleep. So around 1.5 to 3 months, we are able to start differentiating this, and this is quite important. As I said, the non-REM sleep is in parallel with actually that cortical development. The non-REM sleep stage 2, you see the sleep spindles and the K complexes pop up. So that is actually again related to information processing. It is related to conserving your sleep, the state of sleep, and how you actually have the brain plasticity ongoing. Even up till today, they are further dividing that non-REM sleep and the microstructure that we call them, and into cyclic alternating patterns. And that is small spindles that we see, small waves that we see returning, and is actually also related to being protective of sleep. So your brain, your body is that perfectionist in making sure that the cells at the brain, that your organ actually gets enough sleep or protects the sleep state. Okay. So around 6 to 9 weeks, these pop up, and end of 6 months. So those are actually also the period where circadian changes happen, where you can see that children start to sleep through the night, and you see these behavioral changes, but it's also because in the brain many things happen, and sleep can actually help us being that window. So the non-REM sleep, now they're grouped together in the stage 3 and stage 4. So the delta waves and the sleep spindles, and then the stage 4, which is actually really related to that restorative function, delta waves. So you really see that the waves, the brain waves, are changing when you actually start and go into deeper sleep. So you, as an adult, you go from the lighter, staying deep, and then you go back up in the cycle, and then you have a REM sleep, which is again different, random, fast, saw-toothed brain waves, and then you go back into the next cycle, and on and on. So this is actually happening throughout your first life period. Your sleep matures, your behavior matures, your brain matures, and that is actually a key element in atypical developing children. So, and then in neonates, there's quiet sleep, active sleep, and indeterminate sleep. So a lot of things happen, and I'm very brief here, just to give you a basic idea. So if I summarize this differently, and Dr. UBC already showed you a hypnogram. So you have here stage 1, stage 2, stage 3, 4, the REM sleep, and then when you actually go from one state to another state, and especially to the REM, you turn to move, and then it's actually a movement that you can register throughout sleep. So without having the brain wave or electroencephalogram ongoing or polysomnography, what you can do is already, as any healthcare provider or parent, is look at the bedtime, the get-up time, or the wake-up time, because that gives us an estimate how much time a child spends in bed. We look at the time that the lights are off and the child actually falls asleep. The sleep onset latency is kind of predictive of the quality and duration of the sleep. Then also at the end, the get-up time, the wake-up and being fully alert, or the sleep offset time is even informative because, as I said, it's a flip-flop switch, and when it's actually fulfilled, the need is fulfilled in terms of sleep, then you will become fully alert. That's where I have problems with when I'm jet lagged. So the sleep inertia is my brain doesn't simply get to that wake state, and that's where we as adults tend to go for coffee, or do things that really make our brain waking up. So the sleep inertia is quite informative. And then actually based on the sleep onset and offset, we can have an estimation of the time spent to sleep period time, without knowing anything about the brain. So that gives us an estimate as a clinician, as a parent, about the quantity of sleep, the duration of sleep. Now for children, as I said, a lot needs to happen on the microstructures of the non-REM and the REM sleep and the subdivisions and how it is divided throughout your day, and then it needs to move to the night. Many things happen in that first period of your life. So as you can see, and I showed it, it's like at the beginning they have most of their deep sleep, and towards the morning they have most of their light sleep. And the best example I can give you, if you have children, when you come home from a party and you take them out of the car, at elementary school age, they are sound asleep, and you can do whatever you want, but they are not awake. If they wake up, the best tip I can give you is actually do the same rituals you would do at bedtime to make them calm, relaxed, and fall asleep in bed. Most of the time they're so sound asleep because they're in that deep sleep. Now, why is it important to show you this? Well, given all this information, as a sleep clinician, it is informative to know when certain behaviors happen at a certain point in time throughout the night. Because as you can see, we can relate them to certain brain waves or to certain periods throughout the night. It would go into too much detail to tell you all about this, but this actually expresses you the quality of the sleep. And then adding to that, it's the total sleep duration, sleep wake pattern. Where does sleep fall within our 24-hour cycle? And especially in children with atypical development, it might be a completely circadian flop. So the sleep duration, and in typically developing children, we all tend to see that they all tend to sleep less. And then, of course, new research questions are what happens to that sleep architecture, what happens to that non-REM distribution and all those stages. So the sleep regularity is another aspect that is key to pick up from our nighttime behavior. And as I said, something totally forgotten within sleep research is that wake-up time. Most people study this falling asleep, but not, do you wake up spontaneously? That's a key question. So it's about the opportunity to sleep, and in some cultures it doesn't matter if you fall asleep in the sofa or in a group, or other cultures say you need to sleep separately in your own room. So the opportunity to sleep is important, especially for children, given to the fact that it is related to brain development and development of the child. So I think that for now I have convinced you that sleep is indeed a vital function, a vital behavior. You've got a speed course, fast forward course in sleep to now use your common sense to anything else that I'm going to tell you after this, and advocate with us the importance of sleep in children with atypical development. So let us have a peep at those nighttime behavior relationship. As I said, there's a lot still to be known, but then again, what we know in terms of learning and memory, well, your brain develops, you know, when you start talking, sitting, walking, it just, you know, it doesn't happen like this. It's because, like, every second there's 40,000 synapses ongoing and your brain is just forming non-stop, and the key element there is sleep. So the white and the gray matter is continuously developing, and the white matter even all the way into your adolescence period. So your brain is really an important organ that is still being formed way after birth. Imagining those children that do not get the optimal sleep. So there's a lot of changes happening, structural, functional, behavioral ones, and for most of the developmental aspects, we can actually make a developmental profile when you need to walk, when you need to sit upright, when you need to talk, when you need to use your full sentences. So that developmental profile is there in terms of sleep. Still a lot is to be done or studied, and especially in terms of children with atypical development, a lot is still an open question. So if I would summarize again in terms of learning and memory, if sleep is restricted, and this was in adolescents, that you see that the areas in the brain that are involved with the task at hand, task at hand, and the areas that are not involved with the task at hand actually hyperpolarize. So when sleep was restricted, those that actually are involved with the task become hyperpolarized so that you can still perform, that you can still maintain a good performance. In terms of deprivation and loss, either it's partial or it is complete. Is it only REM sleep? Is it non-REM sleep? So depending what happens, you can see that the psychomotor abilities are getting worse, your reduced awareness, adaptive skills become worse, your learning capacity is worse off, and so on. Executive functioning and the higher cognitive functions. If your sleep is considered as poor, quote unquote, is it the quantity, the quality, or regularity is poor, then actually has been associated with poor scholastic performance, problems with working memory, and we do not need to tell you that, because you know if you haven't had a good sleep that you go like, oh, what was it again? So working memory, reasoning, comprehension, fluid intelligence, and the CAP I just mentioned, so the cyclic alternating pattern. As I said, there is something ongoing in your brain that makes sure that if there's too much noise, there is interruption, or your sleep might be intruded, then this activity will preserve your sleep. The reverse happens also, another aspect happens also when you're like fully awake, but you're like deadly tired. Your brain will eventually protect itself by making microsleeps. And that's where Chernobyl and all these big accidents happen, because the brain is trying to catch up that sleep that it needs, because on the molecular level, on the neurotransmitter level, things need to happen to preserve its function. Fragmentation, either intrinsic or extrinsic, attention, executive dysfunctioning, disordered, and I think this is a key model in terms of chronic sleep deprivation, because children with sleep disordered breathing, especially the sleep apnea, has been widely studied. And it's a good model. There's a lot of animal models there as well. So it's a good model to look actually what fragmentation of sleep is doing. Unfortunately, you have the hypoxia, you have the arousal, so there's more components to it than just plain fragmentation. But nonetheless, it's a good model, because actually what we've seen is that when these children are treated, their actually performance improves. So I think that's a proof of the fact, or the concept, that sleep is important in your performance, in your behavior. So, and it was not only the apnea, the stopping of breathing, but also the snoring actually has been related to scholastic problems and problems in terms of acquisition and recalling, and that especially during childhood is not the key thing. If you're not open to learning, if you're not learning what is being taught to you or being expressed to you or shown to you, then also your behavior and the next night might be influenced as well. So these children with sleep disordered breathing are characterized by sluggish cognitive tempos, like they don't get really awake because they have that fragmented sleep. And then variable and irregular sleep, as I mentioned, we've shown in Chicago that actually increases the likelihood of obesity. And if you are obese, your likelihood of sleep disordered breathing increases. And then we start, is it multiplicative or is it actually cumulative? So the chicken and the egg, it becomes quite clustered or blurred, but in the end, the night wake is linked. And if you treat one, we see that the other one improves. If we improve the other one, we see that the nighttime as well improves. So it goes in both ways. And then in terms of extension, very few studies have been done in children with all these restriction, deprivation, or fragmentation, because ethically we cannot really have typically developing children have less sleep, especially if we know that it might affect their brain development and their learning capacity. Now, extension, they've tried to have children extend their sleep with 1 hour, and what we've seen is that they only succeeded in extending it for half an hour. But then again, in these children, their vigilance increased, attention, memory, all those skills or all those functions that are important to learn at school or in atypically developing children to be open to have the behavioral treatments learned to you will improve. So that is in terms of extension. And if its sleep is poor, is deprived, is restricted, you actually see that performance goes actually down. So bottom line, inefficient daytime behavior, variability in performance you can expect when sleep is not the quality it should be, or not the duration it should be, or not as regular as it should be. So sleep affects cognition, emotion, and behavior, but also cognition, emotion, and behavior will affect sleep. There are animal studies that actually show local sleep enhancement, if I express it correctly. It's that with having animals exposed to certain tasks that affect certain areas in the brain, they could actually create a flip-flop switch at that local area in the brain. So I think that's quite promising because most of the studies related to this learning and memory and consequences of sleep or poor sleep have been pushed forward by sleep disordered breathing. But most of these studies have assessment of the performance of a child after their sleep study. So it is sleep affecting cognition, but not as much cognition affecting the sleep. But we do know if we learn tasks before sleep and we have a good sleep, that the tasks are better preserved or better learned. So cognition, emotion, and behavior, and if you had a fight with your partner, you know that your sleep will not be quite all right that night maybe. So that is also proof of the concept that it goes both ways. In terms of REM and non-REM, I'm not going to go into detail, macro and microstructure. As I said, those tiny little spindles have been associated with our learning capacity. Developmental profile of functioning, we do not know yet at those different ages how much different will the outcome be or how much different will the consequences be. We for now actually come to agreement that inefficient daytime or variable performance is seen throughout the lifespan. Another aspect is individual need and vulnerability. I'm quite lucky that I can sleep on the flight, and probably that's why jet lags are bad, but not as bad as some other people might suffer. So there is still that individual need, because as I said, there's a huge variation also in sleep duration. So some people might have a need for a lot of sleep, and others might have a need for less sleep. So affecting these people with different or poor sleep might have a different outcome as well. And then which functional domains, most of the studies will show in executive function or attention problems which is quite common in children if you know the brain development. So plasticity is a key element here in terms of learning and memory. Don't underestimate the capacity of the brain. So this is a very dense slide, and I go very rapidly through it because what I want to have you take home from this slide is that since it is a brain, it has, it is attention, it is memory, it is all these separate functions, but in the end it is one person, is one brain. It's the same for sleep. You can have this sleep problem, but then the other sleep problems might be present as well, and it might become difficult to disentangle everything. But the key from this slide is that disorders of initiating and maintaining sleep and disorders of excessive somnolence are the top complaint in typically and atypically developing children. And of course, it's all related, interrelated, and that's what this slide shows. So the dysomnias, the problems that actually the initiating, maintaining sleep and the early awakenings versus the parasomnias, the behaviors that disrupt your sleep or show up in the middle of your sleep. And then again, the sleep environment or the sleep ineresis, sleep efficiency are actually also interrelated to all these aspects. So key message is that they are clustered together, they are related to a certain degree to each other, and that makes, especially in children with atypical development, it quite difficult, I think, to filter out what are we looking at and what is actually at hand. Another dense slide to show you is a model that tried to link all the elements that we know: parental problems, psychosocial problems, health problems related to, so this is family demographics, family dysfunction, the person most knowledgeable, so the psychopathology in the person, difficult temperament, child health, sleep problem, internalizing, and the same here for externalizing. And what you see, all of these will add into a certain degree, will add into internalizing or externalizing problems. And especially, the sleep problems come in. And again, you see here for internalizing problems, it is the person that is interacting with you mostly, and then the negative parenting. So if you talk about daytime and nighttime behaviors, they are separately interrelated, and then again interrelated as a total, and then you have to embed that within a certain context, within a certain parenting, within a certain society. And that's where we are at right now within pediatric sleep. So again, to summarize, it is not only their frequency, which is quite mostly or commonly looked at, it's also their severity. Very few questionnaires look at the severity or the chronicity. How chronic are either of these problems. Either you start from the daytime, or you start from the nighttime, or you start from the whole context around it. So again, the same aspect on the one side, that you cannot forget one related to the other one, and that is actually that co-occurrence, morbidity, comorbidity that we are facing in these children. So summary is that, if I can conceptualize it, so throughout your development, you have your duration of your sleep will actually affect what happens throughout that sleep period, that behavior, and it will eventually pop up as problems in terms of arousal, or problems in terms of sleepiness, or some nighttime behavioral problem. Mostly it will be initiating and maintaining sleep, or the early awakenings, and it might be a non-optimal total sleep time. And most of the clinicians or most of the healthcare providers will train your sleep hygiene, all those aspects that will promote sleep. It's not having caffeine, it's having a comfort area to sleep or environment to sleep, all these aspects that might promote sleep. And then you see, in terms of health, throughout the studies, if I can summarize them, variability comes into play as well. So the variability, because it might affect the health if you're very unregular, like me now, going back and forth from, so I arrived here, then I flew back to Chicago, back to Vancouver, now we'll go to Europe again. So all these changes, this variability will likely affect my health. And for me it's mostly my eating habits, but just maybe a couple of things. And also my nose is, I'm a small eater, and I always go like, oh, not too much food, because I know it disrupts, but it might be any aspect. It might be blood pressure, so the health, the behavior, the duration, variability, arousal, and sleepiness. It's all that way interrelated. It's all connected to each other, and you need to filter each of these elements to fully understand what you're looking at. So, in a quick nutshell, the night and daytime behavior, I think you're now pretty much convinced that it is linked, and that if one is present, it's very likely that another one will be present as well. And as I will show you now in the last part of the presentation, the Sleep2Treat, which will focus on the children with an atypical development, all this will come into play in this puzzle pieces. So the Sleep2Treat, well, as I said from the beginning, we know when the social smile, you know, your first smile, and we're proud of it, baby smiles at me. The first steps, we're proud of it. The first word, we're proud of it. The first time they have their solid food. And, you know, as a parent, all these elements, you know, you go like, wow, oh, my baby is doing this, and you're very proud. Because they're indicators that the child is developing well. The child is actually on track. It's the same with sleeping through the night. If you have the school gate, that will be like a key topic in terms of when do you put your child to sleep, and mine is sleeping through the night. Oh, first night that we can sleep as a parent. So even though it is so important compared to all the other aspects in development, there's still so many questions unanswered. So, as I said from the beginning, sleeping is actually a key behavior, a key function for a child. And actually it is engaged in sleeping more than in any other activity, more than in playing, more than in eating, and more than in social interacting. And still, there's so little attention paid to it. So the disturbance of sleep is, as I said, one of the most frequent child behavioral problems reported by the caregiver. And the caregiver is key in terms of childhood. And they need to become trained, as a healthcare professionals need to be trained to become aware that you not only focus on the nighttime, but also on the daytime. If you see externalizing behaviors or internalizing behaviors, how is also that component around sleep? Don't only look at the things that you have commonly trained in. Because the disturbance of sleep will depend on the caregiver, because they will help you define it. They will help you in understanding what is the cause, and they might be the cause, and they might also be the ones that maintain the sleep problem. So in terms of the measurement, it is quite important to keep that in mind, because a complainant might be different from the sufferer and might be different from the observer. I gave a talk or a lecture in Shanghai, and unfamiliar with the bedtime rituals of infants, you know, I got this question. I really had to scratch my head, like, how am I gonna answer this question culturally correct? Because I perceive it as an observer from my Western culture, and how I would actually train or treat parents within the Western culture. So that's an important aspect in terms of defining a sleep problem, and also in terms of treating the problem or the complaint or the disorder. And why is it? Because sleep is a primary activity for a child, and it affects its 24. It's not only at nighttime, it's also at daytime, day nap. So it affects not only the child, but also the family and the community, and it actually requires an interdisciplinary approach. So now specifically, in a nutshell, in terms of children with an atypical development, well, there's very few studies. It's kind of booming right now, and I think Osman is a cause. The topic is an eye-opener within the field of sleep. But what we actually should pay attention to is that within each of these syndromes, within each of these groups of children with atypical development, there's a huge variability within the same type of subject. And that makes it even more cumbersome, makes it even more difficult for us to fully grasp what is ongoing. So a couple of the aspects that I will try to puzzle here also fit for typically developing children, but are even more important for atypically developing children. So in terms of generalizability, what we know right now and how can we expand that knowledge to other disorders or other treatments or other ways of diagnosing or assessing, well, age is a key element when you work with children, we all know that. And then the comorbidity, given the fact that the brain is still developing and actually maturing, so the comorbidity, the co-occurrences, and the development of these associations, they might differ when the child grows up, is a key element and will actually keep hampering us in the generalizability. Now, different cutoffs have been used, especially in terms of typically developing children. What is a sleep problem? What is a sleep disorder? It is quite often an indirect assessment. We rely on parents, and different criteria are being used. And I remember when I first started with sleep disordered breathing, the apnea-hypopnea index, it swapped all over the place. And I was in Dr. Ghazal's group, leading guy in sleep disordered breathing. I was like, Dr. Ghazal, make a consensus. But it's quite hard to see the criteria that are being used and the elements to define a problem or non-problem aspect. So the child's input is of course key when you talk about sleep problems, as my previous slide showed, but it's not always easy. And most of the questionnaire studies are mostly relying on parental report. In terms of atypically developing children, the picture becomes more complex because the medical condition, the mental condition, the physical condition, the sensory aspects, the motor aspects will all add into a different expression of potential sleep problem or sleep complaint. They might be quite focal areas in the brain that are damaged and actually affect the sleep or the regulation, sleep-wake cycle, the circadian rhythm, and there might be all diffuse, and that actually gives another behavioral repertoire or profile. Another aspect is that tolerance. There are a few studies, but a couple of them show that parents of children with developmental disabilities have a different tolerance, and if they need to describe a sleep problem in the child with a disability versus the child without a disability, you actually see that they are more sensitive or have a different perception of labeling the sleep problem. They have, throughout the years, might have developed adaptive behaviors that, they are no longer aware of that it is an adaptive behavior, and that might even reinforce the behavior of the child, or might actually aid the whole issue or aid in throughout a better sleep. So that actually will make it, the generalizability difficult as well. In terms of dosage, I think Dr. Carlton will mention it as well. The dosage of the medication and the adverse drug reactions is something that will make generalizability within this group difficult as well. The psychosocial aspects. And then as a result, most of the sleep problems in these children are misdiagnosed, or they have mixed ecologies, overdiagnosis, or there's an overestimation of their quality of sleep. Sleep readiness, as I said, these children, because of being sleep deprived, of having poor sleep the night before, during the day might not be open, to all those sleep promoting behaviors that you're trying to learn them or adjust to. So the sleep readiness might be different, or variability in sleep intervals. The sleep architecture is changing. If you look at the sleep architecture of a child with Rett syndrome, it's quite hard to score it. And paradoxically, when they have issues with breathing during the day, they don't show them at night. So it makes it quite complex, and sleep architecture is something that is quite intriguing in children with atypical development. I'll show this again. Daytime behavioral problems might interfere. The individual preferences might be different from environmental. If they need to sleep in special beds or have certain treatment equipment around them, ecological hygiene might be different. All these elements make this group of children quite challenging in terms of sleep studies. Food patterns, drinking patterns, as I said, those biological clocks, the living condition might actually all influence the sleep of these children, and many, 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 many more. And I'm hoping that this group will eventually show them or elucidate on these issues. So I do not know how many parents are in the audience, but for those parents that are in the audience, I did my best to summarize a little bit of the knowledge regarding sleep problems in children with an atypical development and what they can learn as well. First of all, it's quite common, very common, and probably do not need me to tell you, but it's surprising that it is such a complaint that there's so little research ongoing. So most of the complaints will be initiating and maintaining sleep, and the fact that the sleep-wake pattern is arrhythmic, and in some children the sleep circadian rhythm will actually flop or switch. So somnolence is a key complaint, or daytime sleepiness, as well as sleep disordered breathing, or because of their upper airway issues, they are more prone to sleep disordered breathing, and then they fall into those behavioral problems as I've mentioned. The decrease in total sleep time is quite often seen. For example, in children with Angelman syndrome, initiating and maintaining sleep is suggested, as well as the awakenings at night. And then movement, restless sleep, or even the restless leg syndrome might pop up in these children with atypical development. Then you see the parasomnias that might show circadian rhythm disorders. In terms of Prader-Willi syndrome, what you might expect is again sleepiness, increased number of naps, the sleep disordered breathing issues, as well as an increased risk for narcolepsy. Initiating and maintaining sleep issues. Rett syndrome, as I just said, is decreased number of REM periods, sleep periods, which then is related to memory and again openness to behavioral therapy and brain development. So decreased or shortened total sleep time, increased number of naps. Down syndrome, again initiating and maintaining sleep, sleep disordered breathing, circadian rhythm issues, as well as an anxiety to fall asleep, something I forgot to mention. These children might have difficulties to go to sleep or resist to go to sleep because during night they have sensory aspects or it feels uncomfortable, and that might, make them reluctant to go to sleep. It's something we might not have questioned or considered. Cri du chat is, and again, initiating, maintaining sleep, sleep disordered breathing, the parasomnias, anxiety again to go to sleep. The Cornelia-Delange, you have initiating, maintaining sleep. And then the Williams-Byrne, initiating, maintaining sleep. So again, these dysomnia aspects that pop up, the movement issues, the circadian rhythm problems, and again, the anxiety. The Smith-Magenis one is actually one of them at the top ranked in terms of sleep complaints because they have bursts of sleep with prolonged periods of awakening, initiating, maintaining sleep issues, somnolence, the decreased total sleep time, circadian rhythm issues. Then pervasive developmental syndrome, you have initiating, the awakenings, then the movement issues, the sensory aspects, and prolonged time to fall asleep, and then decreased sleep offset latency. Metabolic neurodegenerative disorders, again the initiating complaint, so that always comes to the maintaining fall asleep, so the transition from that wake state to the sleep state, either biologically or environmentally or behaviorally induced. Parasomnia, the sleep disordered breathing, the circadian again. The neuromuscular, of course, as I said, upper airway issues, so the sleep disordered breathing, initiating and maintaining. The cerebral palsy one is sleep-wake transition problems, the initiating, maintaining. Children with rhinitis, sleep disordered breathing. Children with asthma have sleep disordered breathing, decreased sleep duration, and of course the awakenings. If sleep is not optimal in these children, their daytime behavior will not be optimal and will be affected, and we go on with a potential vicious circle. A decreased stage 4, that restorative sleep. Cancer has been studied. Again, the awakenings, also the fact that sleep is not comfortable might actually prevent them to fall asleep, so initiating, maintaining sleep, and the number of wake time is actually increased, as well as the quality of sleep is increased, and as a result of the somnolence, the pain. It's again decreased number of sleep duration, the quality of sleep is influenced, the awakenings are again there at night, initiating sleep and maintaining sleep, and potentially also the sleep disorder breathing. So, the craniofacial aspects, again, the sleep disorder breathing, the epilepsy, which is quite challenging in terms of scoring sleep. You have again the architecture that is affected. And there are so many other things that we probably have not thought of and we still need to study in terms of syndromes or overlap of symptoms among these children that we might better understand from a sleep perspective. And that's why I put it like this. Because there's a one tiny turning point, and that turning point each of these studies will mention is that the prevalence and the degree of a sleep problem equalizes actually the severity of the brain impairments. And it can be quite global and it can be quite pronounced issues that pop up. So in terms of what we need to do is these adverse effects of chronic sleep disorders on brain development. And if you can see, I flipped it because to me, you don't only start from the syndrome and look at the sleep, but look at the sleep and see how they actually go back to certain syndromes where the overlaps are. Because to me, Sleep2Treat is a different viewpoint, a different perspective on the same brain, on the same child, in the same ecology, in the same context, same genetic composition. You look at nighttime behavior. So the effect of long-lasting sleep loss, I'm very sure that children with an atypical development will help us elucidate way much more of that sleep and sleep health tailored to their strengths and weaknesses in the key. So if I can summarize it in these children, again, the right gray matter, structural and functional and developmental profile, then these children, all of these have. You know, there's a restriction, there's a deprivation, there's sleep is poor, fragmented, and so on. And it might be that the physiology, the sleep-wake pattern, the circadian rhythm, the comorbidity, the co-occurrences, everything again is that much interrelated, and a few studies that have been done have not been able to elucidate the real turning points. So in these children, it is quite often seen as an inevitable part of their condition, and so their developmental profile, only in terms of sleep, might be very informative, especially their individual need and vulnerability. And it's quite, as anybody will say, overlooked, either neglected or simply endured. And so the treatment might be discouraged or discouraging to parents because it was not optimal, it just didn't fit the problem or the conditions they were dealing with. So to then conclude, these children have, the desired sleep when it is desired, expected, and needed doesn't always fall together, and that's where we, with the Sleep2Treat, need to come up with solutions. So I think I have to round up since I see Osman standing. So from a neurodevelopmental or neuropsychological perspective, you see structural changes interrelate to these behavioral and functional changes. You don't only look at the chronological age as a psychologist, that's why you train that, but you should also look at the developmental age. I firmly believe that in children with atypical development, that is actually key in terms of brain development and their maturation. So sleep is of, by, and for the brain, don't ever forget that. And then age at the time of disorder, the age at time of testing, time since the disorder, and the cognitive abilities. So timing is crucial given the fact that brain maturation and brain development and child development should be seen as one. And then nature, severity, and chronicity, as well as short, medium, and long term, and especially that long term is important. And then the morbidities that are there, because that will actually help us define the frequency, the severity, as well as the chronicity. Brain plasticity, I think that speaks for itself. And then the last part is, of course, the context. The context of parents that maybe endured or have developed adaptive behaviors. So that's quite important to stand still or reflect on as well. So, Osman, if you allow me a couple of minutes. So what we have done so far is through this scholarship, we have been fortunate to work on fetal alcohol syndrome, and I see the brains that work with the data right there, the students. They have, we've been lucky to have fetal alcohol syndrome data, and also asked me last minute to flip in a couple of slides of this. So what we have been trying through this scholarship, my presence here, is that all of what I've said, these interconnections, to disentangle this, so to make sure that each professional that is involved within the care of children with neurodevelopmental disability to come to that common language. And so we've tried to make, or at least tried to make a taxonomy of transitioning. Why transitioning? Because what I've just said in terms of that flip-flop, it is a passage from one state or style to another one. And for me, it is in terms of sleep to sleep, or sleep to wake, or wake to wake, or wake to sleep. So it's that transitioning that is happening that we're trying to express in functional terms, express in a taxonomy to help us understand better and talk in the same language. So the process of changing. And what we have divided it into is cognition, behavior, emotion, sensory, motor health, and adaptive functions as sides of a cube. And so inside, it's an imploded cube, you have the perspective of the child, the caregiver, the professional, and the others that can be educators, that can be funding or pharmacy, pharmaceutical companies. So that cube will allow us to come to analysis because we understand each part of these transitioning, or each part of these state transitioning in a similar way. And then hopefully we can develop strategies. So the child, the parent, the professional, and on the other side you have the others. So in terms of cognition, which will be subdivided in certain details or certain detailed functions. Same with emotion is the other side of the cube. Behavior is another side of the cube. Health is another side of the cube. To just make everybody that is involved with the children come to kind of a self-awareness that we actually look at the same child, but each from their discipline, occupational therapist, a psychologist, an MD, and that we look at these sides in a similar way and divide the functions, so eventually we can come up with strategies. And the data that we've had at hand, and I think Osman will show them, has been analyzed already in the first stage throughout that model. So I think I'll leave this out. We've done this in terms of the text mining as well, but I think Osman will explain later on. Okay. So I think I need to put the last slide on, the most important one. This one. Thanks to everybody for first of all listening, and the Peter Wall for sponsoring this.